Hello students, I am Dr. Ashutosh Agrawal. I hope your CBT for the FMGE exam has gone well. So we'll be discussing the questions which were asked in the subject of the pediatrics. Right? So first topic are rickets, which is a very important topic for the FMGE exam. If you see here, a 7 years old girl presents with recurrent, the word here is recurrent onset of genu valgum and difficulty in walking. On X-ray, there is metaphyseal widening and osteoporosis. The serum calcium is 9. 9 to 11 is something which is the normal range, you know. Serum phosphorus is 2.5, which is definitely low. And alkaline phosphatase is 30 King Armstrong unit. There is also history of the rickets in the brother and the mother. What is your probable diagnosis? Now, in the clinical questions, the method you should follow always is the exclusion one. Exclusion. So, if you see here, the phosphorus is low. So, this cannot be chronic renal failure because in chronic renal failure, there is hyperphosphatemia present. There is hyperphosphatemia present. So, this cannot be chronic renal failure. This cannot be primary hyperparathyroidism because in primary hyperparathyroidism there is hypercalcemia present. Because if the PTH level is more, the calcium level should increase. That is not there, right? So if we look here in hypophosphatemic rickets also, the serum phosphorus is less. Serum phosphorus is decreased, and nutritional rickets also, the serum phosphorus is decreased, right? Now if you basically see out of the two, what is being given is there is also history of rickets in brother and mother. So this seems to be more on the familial side, right? And if it is more on the familial side, then you should choose the answer as hypophosphatemic rickets, which is actually X-linked hypophosphatemic rickets. This is the X-linked hypophosphatemic rickets, and it is a X-linked dominant condition. It is a X-linked dominant condition. That's why the mother is having, the brother is having, maybe sister is also having, as is given here. So always while solving such MCQs, first try to exclude 2. If you have excluded 2, then you can easily come to the solution here. Moving on to the next question, again a question of short stature, important for you. A 10-year-old girl is brought to OPD by her parents who are worried that she is the shortest girl in her class. Her height is 100.5, weight is 26, right? So if you see a 10-year girl having a just height of 100.5, that is very short stature, because normally 100 centimeter is attained at the age of 4 to 4.5 years. That is the normal thing. So now in this child, the child is 10 years and she is short. The rest of her physical examination shows nothing abnormal. Father is 175 centimeter tall and mother, who attained menarche at the age of 16 years, is 165 centimeter tall. The patient's wrist X-ray shows a bone age of 8 years. So the point favorable here is both parents are normal in height. If you basically say here, both parents are normal in height. And the moment you say that both parents are normal in height, this rules out genetic short stature, because in genetic short stature, one or both parents are short. Then the positive point here is bone age is less than chronological age. That is there. Now this cannot be seen in genetic short stature, that has already been excluded. And the growth hormone deficiency, it can be seen. Constitutional growth delay, it can be seen. Chronic malnutrition, it can be seen. Now in the malnutrition, the weight for age should also be less, right? And a 10-year child with 26 kg weight is approximately well That cannot be a malnutrition. So as the weight is normal, we rule out the chronic malnutrition. We rule out the chronic malnutrition. Right. Now we come to the two things, whether it is a growth hormone deficiency or it is a constitutional growth delay. As there is history of delayed, particularly puberty in the mother, which attained menarche at the age of 16 years, we basically take it in the form of constitutional growth delay. So this is most likely a case of the constitutional growth delay, where all the findings are there. Both parents are normal in height, bone age is less than chronological age, and you need to remember here that ultimate or final height is normal. Ultimate or final height is normal, right? So this is regarding this thing. Moving on to the third questions. Characteristics of caput succedaneum include all of the following except. We are talking of the capitis. A child was suspended in the vertex, face or brow presentation for long, and due to gravity the fluid settled down, right? So this basically is a subcutaneous swelling. This is basically a subcutaneous swelling, right? So the basically point, this is correct. It is a diffuse edematous swelling, and anything which is superficial, this can cross the suture line and this can cross the midline. So this definitely can cross the suture and midline. This is present at birth. This is present at birth, and this usually disappears in 2 to 3 days. This usually disappears in 2 to 3 days. So if we say this is a subcutaneous swelling, this will cross the suture and midline. This is present at birth, and this usually disappears in the 2 to 3 days. So the line saying that it does not disappear within 2 to 3 days is not right. This disappears within 2 to 3 days. Next one, a newborn whose estimated gestational age is 42 weeks is stained with meconium. The infant has respiratory distress. A chest radiograph is obtained. Of the following most likely radiographic finding is. So 42 weeks, so called, you can say post-term child, right? Although it will be more than 42 weeks post-term, but we can say this is basically post-term child here, which is having the meconium aspiration syndrome. Meconium aspiration syndrome. Now to understand the chest x-ray, what you need to understand here is what is the mechanism of lung damage. What is the mechanism of the lung damage? Now if you look at the mechanism of the lung damage, this is a chemical. So any chemical can go, and this can cause chemical pneumonitis. Chemical pneumonitis. And if there is chemical pneumonitis, basically there is the lung infiltrates, which is the most common chest x-ray finding. Most common chest x-ray finding. Second, it can cause partial obstruction of airways. So if there is partial obstruction of airways, what will happen? During inspiration, air will enter, but during expiration, air will not come out. So this will result in emphysema. Emphysema. Then there can be complete obstruction of airways. And due to complete obstruction of airways, there will be atelectasis. So in the x-ray you can get this collapse, and then there can also be secondary surfactant deficiency. But if you see which is the most common chest x-ray finding, the most common chest x-ray finding is the lung infiltrates. This lung infiltrates is the most common chest x-ray finding. So the answer here is the coarse infiltrates. That is the most likely. You can also get decreased lung volumes. Because of emphysema, you can get mediastinal shift, but the most important to be remembered, they are asking the most likely, answer is coarse infiltrates. Full-term baby exclusively breastfed at the end of 1 week was passing golden yellow stool and found to have adequate hydration with normal systematic examination. The weight of the baby was just the same as it was at birth. The pediatrician should now advise, right? Now, if you particularly see, one is the color of the stool, that is the golden yellow stools, and this can be the transitional stool. This can be the transitional stools, and this is something which is very normal in a child. Nothing to be done here, right? Although the point can be the child is not losing weight, that is because the child should lose weight. It is not like this. Even if the child is not losing weight, otherwise all the things is normal. So you need to reassure the mother that nothing is abnormal. Investigate for lactic acidosis. It does not carry any significance, and you should not start top feeding or oral solution. Right? Nothing to be done. These are transitional stool which are normal for this age. Which are normal for this age, and nothing to be done here. Yes. All of the following are true regarding the lab finding of idiopathic nephrotic syndrome except. Now, when you say idiopathic nephrotic syndrome, we are talking of the minimal change disease, because the most common cause of nephrotic syndrome is the minimal change, and in the minimal change the age group is 2 to 6 years of age. Now, what you remember here is serum C3 level is normal. There is no hypertension or hematuria. No hypertension or hematuria. And if you see what are the features, there is proteinuria, there is hypoalbuminemia, there is hyperlipidemia, and there is lipiduria. Right? So these are all the features which are seen. So serum albumin is generally less. Yes. Cholesterol is elevated, less. Renal biopsy is usually not required, right? It is only required in certain conditions, not in every child. That is also true. So except goes in favor of that C3 and C4 are elevated. No, they are normal in the minimal change disease. They are normal in the minimal change disease. What is the most common cause of acute onset of thrombocytopenia in an otherwise well child? So you're talking of the acute ITP, and this acute ITP is usually seen in 1 to 4 years of age after 1 to 4 weeks of viral infection. So what basically happens is antibodies are formed against virus. This reacts with the platelets and they damage the platelets. So this results in the thrombocytopenia. Right? So basically the cause here is autoimmune, that is the antibodies which are formed against the virus which are damaging the platelets. Right? So the answer here is the autoimmune. Going on to the next one. A term infant is born with a patent ductus arteriosus. Its closure can be stimulated by the administration of. Now, what you need to remember is PDA is normally seen in a preterm child, and this is seen in the congenital rubella syndrome. If there is PDA in a term child, if there is a patent ductus arteriosus in a term child, it is due to muscular defect. Which cannot be closed by drugs. So if there is particularly patent ductus arteriosus, right, in a term child, the answer is not any drugs, the answer is surgery. A very tricky question, but this is something you need to remember. Preterm child, you give prostaglandin inhibitor, but in a term child, what you are giving is the surgery is the answer here. Newborn is having the cicatricial skin rash in dermatomal distribution. This is suggestive of infection by. A newborn is having a skin rash. So if we think in context of the intrauterine infection, if we think in context of the intrauterine infection, one is the herpes simplex virus. There is also skin rash in the dermatomal distribution. There is also skin rash in the dermatomal distribution. And second is the varicella zoster. In varicella zoster, there is a skin rash in the dermatomal distribution, but that is cicatricial. There is cicatricial rash which is present in the dermatomal distribution. So cicatricial basically means is associated with fibrosis. Associated with fibrosis, and in varicella also there is hypoplasia of limbs. There is hypoplasia of limbs, right? So therefore the cicatricial is in favor of the varicella zoster virus, in favor of varicella zoster virus. Moving on to the next one, a question related to the milestones. Child can make a tower of 10 cubes, gate of 3 cubes. What other milestones can be seen in this child is? Right? So when a child make a tower, these towers are something which is like this. This is the tower, and this is something that we say is the gate or bridge. This is the gate or bridge. So if you see a 15-month child, 15-month child makes a tower of 3 cubes. 3 cubes. 18 months child can make a tower of 4 cubes. 24-month child can make a tower of 7 cubes, and 36 months child makes a tower of 10 cubes. At 36 months also there is gate of 3 cubes. So if you particularly think here, it is being given tower of 10 cubes and gate of 3 cubes, the each comes out to be 36 months. 36 months. Now in this, if we see, goes upstairs 1 foot per step, that is 3 years. Downstairs 1 foot per step, that is 4 years. Tie the shoelaces, that is now 5 years. Previously 4, now it is 5. Speak sentence of 4 words is 4 years, because it's a rule of thumb from 2 to 5 years child can speak sentence of word equal to the age of the child. So 2-year child will speak sentence of 2 words, 3-year child will speak sentence of 3 words, 4-year child will speak sentence of 4 words, right? So if you see what is seen at 3 years, it is goes upstairs, that is 1 foot per step. This is goes upstairs, that is 1 foot per step. Yes. Then a couple has 2 children affected with the tuberous sclerosis. Now tuberous sclerosis is something which is autosomal dominant. On detailed evaluation, both parents are normal. Which of the following explains the 2 affected children in this family? What we mean to say, both parents are normal, still the child is having the autosomal dominant disorder. And this can be explained by the germline mosaicism. This is explained by the germline mosaicism. Now mosaicism basically means a person is having 2 different type of cells which are formed from a single zygote. So mosaicism implies a person is having 2 different type of cells. There are 2 different type of cells formed from single zygote, formed from the single zygote. And when we attach the word germline, what it means is, let us suppose this is the zygote. Zygote divides into the somatic cells and zygote divides into the germ cells. These somatic cells are normal this germ cells is having the mutation. This germ cells is having the mutation. So when this person will grow, in this person the somatic cells are normal, so he will not suffer from the disease. But where is the defect? The defect is in the germ cells. So each time when he will produce the gamete, he will produce the abnormal gamete. So he will not have the disease, but he will transmit the disease to the next generation, right? So that is what we say is the germ-line mosaicism. Clear? So this is regarding the well explained question. In autosomal dominant, both parents are normal and at least two or more than two child should be affected. Two or more than two child should be affected, then it is safe. Moving on to the next one. Which of the following is the investigation of choice in a pregnant lady at 18 weeks of pregnancy with past history of delivering a baby with Down syndrome? Right. So always remember, if there is a lady already has delivered a child with Down syndrome, then in next pregnancy you go for the direct confirmatory test. In the next pregnancy, you directly go for the confirmatory test. You particularly don't go for the first screening, then confirmation. If a lady has already delivered a child with Down syndrome, you require direct confirmatory test. And the confirmatory test in the first trimester, that is the chorionic villus sampling. That is the chorionic villus sampling. And in the second trimester, it is amniocentesis. It is amniocentesis, right? So already a child with Down syndrome, you require a direct confirmation, and direct confirmation will be done out of this. It is a 18 weeks second trimester. So your answer should be amniocentesis. Your answer should be amniocentesis. Moving on to the next one, which is false about the febrile convulsion? Febrile convulsion. Now, febrile seizures are the most common seizures which are seen in the children. They are the most common type of seizures which are seen in the children. And the age group is 6 months to 60 months. 6 months to 60 months. And they are associated with rate of change of temperature. They are associated with rate of change of temperature. So if the temperature suddenly increases or the temperature suddenly decreases, both can cause the febrile seizure. The seizure occurs early, that is true. Temperature more than 38, yes. 38 to 39 degrees, that is true. Common age, this is true. Aspirin, no. Aspirin should not be given because febrile convulsions are not related to actual temperature. They are related to rate of change. Even what is being said, paracetamol does not decrease. Paracetamol does not decrease the risk of recurrence of febrile seizure. It does not decrease the risk of the recurrence of the febrile seizure, right? Moving on to the next one. A child presents to the clinic with history of seizures and mental retardation. It reveals multiple hypopigmented macules. Hypopigmented macules. So now if you see in tuberous sclerosis, there is ash leaf macule. And ash leaf macule is hypopigmented and they can very well present with the seizures. Neurofibromatosis, there is cafeola macules, but cafeola macules are hyperpigmented, so they are ruled out. In Sturge-Weber syndrome, it is port wine stain, and this port wine stain is basically a blood vessel malformation, so that is again not a hyperpigmented, that is ruled out. Right? So out of this, the most probable answer goes in favor of what? Tuberous sclerosis. Going on to the last one in this, a 7-month-old child is referred to the emergency department with worsening cough. He was born term and has been well till now. On examination, temperature, respiratory rate is definitely increased. There is tachypnea present, right? There is also tachycardia for this age. He has moderate intercostal recessions and his arterial oxygen saturations are 88% in the room air. Auscultation reveals bilateral scattered fine cracks. So what is the most likely diagnosis? Right? Always remember on auscultation, if it is being given bilateral rhonchi plus fine cracks, bilateral rhonchi plus fine crabs, this is bronchiolitis, and bronchiolitis is caused by the respiratory syncytial virus, RSV, right? So clear cut case of the acute bronchiolitis which is seen. Acute tracheitis, this is not the age group. Here the age group is 5 to 7 years, and in bronchopneumonia you will get coarse crabs, you will not get the fine crabs, and in lobar pneumonia you will not get bilateral, that is limited to one lobe, right? So basically this is a clear cut case of acute bronchiolitis, so you can solve like this, right? So I hope most of you people must have solved all the questions right. Wish you all the very best. Thanks.